Okay, next I'd like to ask.
Great. Thanks, Debbie. Good morning, and thank you very much, OLTCA, for inviting me to be a part of this wonderful panel of ladies. I'm pleased to be sharing how Revera is approaching rehab and restorative care. I'm also very much looking forward to listening to my fellow panel members to see how we're all approaching the rehab reform. So first, I would like to provide an overview of how Revera is addressing the change management initiatives post-PT funding reform. There's a large amount of work to be done to adjust to the new model and to ensure continued high quality and best practice care. Next, I'd like to present Revera's operational model of restorative care. I believe that even with all of the changes, if we stick to the true philosophy of restorative care, we won't go wrong. Next, we'll take a look at the MDS outcome scales and how they can be used as predictors of restorative potential. This is not a new item, but I also believe that now more than ever, we need to use the tools we have and focus on the outcome data that we're already collecting to evaluate and to care plan effectively. We don't need to reinvent the wheel. We don't need to work harder. We need to work smarter and more efficiently. Finally, I'd like to close with a look at the tools Revera is using to evaluate the effectiveness of our restorative and rehab programming, as well as track the impact that the PT reform is having on our residents. So post-PT funding reform, there was a large amount of work to be done. So the first step that we tackled was to have a look at our policies and procedures, and were we able to still follow them? So what we had to do was the two primary policies we looked at was our national rehab policy, because we have homes in other provinces. And then we had to have a look at an evaluation of our Ontario rehab policy. Next, we had to look at some other policies that were impacted by the interdisciplinary team. So we looked at our FIRM policy, which is the Falls Intervention and Risk Management. We looked at our restorative care policy, as well as our least restraint and PASD policy, because all of these policies and procedures were impacted. Next, we felt that we needed to shift to an online PT referral form. We felt that this is important to be able to better track types of referrals, numbers of referrals. This involves training registered staff on how to complete the referral forms and our rehab teams on how to pull the reports daily. The third item is shifting MDS coding, in particular Section G, to the nursing leads for all residents that are not on active physiotherapy. I think most homes, there was consistency in Ontario that the physios were coding this section. Given the reduction in their time and their slightly limited scope, this is one area for residents not on active PT that we needed to shift the coding. So this involves a revision of our IMDS training modules. We needed to enhance our education for coding this section to ensure the accuracy of coding and that there were no inter-rater errors from quarter to quarter on the residents. And finally, and probably one of the key areas, is that we need to really work towards establishing clear criteria for post-fall rehab referrals. The utilization was quite high for residents on physiotherapy. Therefore, I think by default, the physiotherapists were reassessing all post-falls. At this point, I think we would all agree that that's not a possibility. So this is a risk area and an area that we want to make sure there's very clear criteria on who needs to be referred and who does not. And we're tackling this. This is a work in progress, something that needs to be done well. So this is something that we're looking at tackling upon review of some of our other policies. So our FIRM policy, which I mentioned earlier, which is the Falls Intervention Risk Management, as well as Revera's SALT program, which is the safe ambulation, lifts, and transfers. So we're doing that work all together. And in my ideal world, in our ideal world, we would love to have an online system that, as our nursing teams post-fall is filling in the documentation that's required, there would be triggers and flags that would send them to an automatic physio referral form. So next is Revera's operational model of restorative care in long-term care homes. As I mentioned, I think that now this is more important than ever. We need to assess and continuously reassess the residents living in our long-term care homes based on a continuum of restorative care programming. These include therapy, dietary nutrition, group exercise, nursing rehab specifically, and recreation programming. This model highlights the importance of the interdisciplinary team approach, including open communication, weekly or twice monthly restorative meetings, depending on the size of your home, and interdisciplinary care planning. And Revera moved to the interdisciplinary care planning in 2013, so we were well positioned to handle this piece. I know you can't see this. You will have my slides available, and I'm happy to discuss, or you can reach out to me afterwards. But just as with most programs in most homes, Revera has created an algorithm to guide our clinical decision-making around restorative care programs. And again, there's been a lot of confusion around the use of restorative care, nursing rehab. I'm talking about restorative care as a philosophy, so that includes all of those interdisciplinary programs. So next I'm going to shift to looking at the MDS outcome measures. As I mentioned, this is not new data. We just need to have another look at how we can use the data we're already collecting in a better way. These are scales that we're suggesting you can use as predictors for restorative potential. Again, not just nursing rehab, but interdisciplinary restorative potential. The outcome scales are, as we know, derived from data collected by the interdisciplinary completion of the MDS assessment. There are a series of scales and indices that can be used to evaluate and monitor the clinical status of a resident. Most of us are using software that offers real-time calculations and up-to-the-minute reporting. These scales also provide aggregate information on resident needs and the complexity of our case mix. So we need to really have a look at it in that perspective. They also provide information to prioritize quality improvement initiatives, and importantly, decisions can be made using this evidence-based information. So I know that this is a busy slide as well, but I'm just using this slide and the next slide are really just two examples of how we've laid out how these scales can be used as predictors of restorative potential. So on the left, the example that I have on the screen is just using the CPS. On the left-hand side column, we define the outcome scale, then we talk about the specific coding sections, what does the score mean, and then on the far right column, we have a clear outline of considerations for restorative care. The next slide, similar example, using the ABS scale. So on the right-hand side, far right-hand column, we talk about restorative goals to increase independence and engagement may reduce the frustration in the responsive behavior. Again, this is interdisciplinary restorative programming. The ABS can assist to understand behavior patterns for motivation and timing of restorative activities. And of course, with this one, managing behaviors needs to be an interdisciplinary approach. Now, I just included this slide because we can't forget that, and I'm not suggesting that, so if someone scores very high and has a severe cognitive impairment, it means they're not eligible for programming. It means they may not be eligible for maybe one type of programming or restorative care, or nursing rehab programming. It just helps us guide our interventions and the way that we approach that resident. So if the score indicates a significant level of impairment, they still require restorative goals to prevent adverse event and quality of care. If goals and interventions are not eligible for the coding in the nursing rehab, that's okay. It's still expected that the interdisciplinary restorative interventions and approach to care will be provided for all residents. Results of this restorative approach will be reflected in the quality indicators, and that's really what this is all about. I had an anecdotal conversation with someone yesterday around when the PT reform took place. A lot of people were panicking and saying, oh my gosh, what am I gonna do? How do I discharge residents? Families will be upset. And I know this sounds very simple, but we sat down with a lot of our teams and said, okay, guys, meet, take 2 or 3 hours. If it takes a half a day, it's the most valuable amount of time. We are in a major transformation here. Meet as an interdisciplinary team, make sure all the key players are there, have your list of residents, so it was like a massive RI MDS meeting and restorative meeting. Go through each resident and think about each resident, look at all the programs that you now have available and figure out where they land, what is best to meet their current needs. And most teams that did that found that 95% of the residents, if they sat as an interdisciplinary team, they knew exactly where that resident fit. And so for that 5% that were left, go reassess them. And then after that, that's the goal every quarter. That's the goal of the MDS, right? You sit as a team and you reevaluate them, and they can float in and out. It's a continuum of care. They can float in and out of the programs being offered in the home. This is a chart. This is not a Revera chart. This was prepared by OLTCA and the ONUS Task Force that Sandra Dudziak and Lisa McEwen sat on. And this just further breaks down for specific nursing rehab programs how the MDS eligibility, how they could be eligible based on that second column, which is showing the specific MDS items that you may want to look at for eligibility. Okay, so finally I'm going to just spend a few minutes talking about quality management and how Revera is evaluating the effectiveness of their rehab and restorative programs. First of all, we have a rehab scorecard, which I'll show you an example of on the next slide. We also have national and provincial PCC quality indicators that we can look at and modify. We are able to track new indicators monthly. We can add them monthly, and then we can get data across Ontario. We have program audits as well. We have RI program audits and very program specific, so recreation program, rehab programming, restorative care programming audit. The RI audits are looking for internal consistencies, and our program audits really combined the ministry standards as well as compliance with our policies. Of course, we all have the ministry inspection protocols as well. And as my colleague Dana Hardy spoke about yesterday, Revera has a resident and family satisfaction survey that's been going on for 3 years, which has very specific targeted data that we've found very valuable, and it's really driving person-centered care and our change initiatives. And finally, we have our annual program evaluation summaries, which are done that incorporate all of the data that is listed in the first bullet points. So I'm just going to close with this slide. I know I'm out of time, but this is just a sample of the Revera Rehab Scorecard. Basically, we have broken it down into quadrants. We create a target. We look at the actual for that quarter. We have a column for an explanation of any variance from our targets, and then what our action items are. And then in the far right-hand side, we just look at a quarter-to-quarter comparison, and then a full annual summary. Okay? So thank you for your time. I appreciate it. If you have any questions, you can ask me at the end, or you can find me after the session.
Thank you, Krista. And now